Welcome to the wonderful world of wellness with Dr. Andy Mencia. This medical program heard from 7 to 7:30 each Saturday right here on WSBR 740 AM is brought to you by the Adult and Geriatric Center under the medical direction of geriatrician Dr. Andy Mencia.
Well, good morning.
Good morning, Dr. Mencia.
Good morning, Anita. How are you?
You look so gorgeous.
Thank you.
People, I wish one day we do need to do this on television because you're such a, are you a clothes horse? I think you are. I don't know what your closet looks like, but you have the most gorgeous clothes.
Thank you. I look forward to going to work. I love what I do. I love my profession. And, I dress for it.
Yes, you do.
Yeah.
You see, when you come in here, I wait for you. On Saturday mornings, I wait. What's he going to wear this morning? That's great.
Yeah, I love what I do, and I love, I love my patients.
I know. We all know you love it. I know who you are, and it's such a pleasure. It's such a privilege, Dr. Mencia. I've had some questions asked of me this week, and I'd like to share them with you. I've had people wanting to have colonoscopies, and they don't know where to go, or they ask me, how often should they have? And I said, I'm not a doctor, but I know a doctor who's going to answer the questions on Saturday morning, so listen.
Listen to the show. We should all after the age of 50, right at 50 or right after then, we should have our initial colonoscopy to get what we call a screening. And the screening basically, I was going to go into GI. But then I got called into geriatric medicine. I got accepted into the program, so I let GI to the side. I said, I'm going to be a geriatrician because of my grandpa being so old when he died. I decided that was my call to become a geriatrician. But I was going to go into GI. As a matter of fact, Anita, when I opened my practice 20 years ago, I used to do the fleximoidoscopy in my office, which is the small portion of the colonoscopy, a smaller version, like 40 centimeter, where a colonoscopy is 60 to 80 centimeters. So I used to do the small portion, which is most of the colon cancer are within 20 centimeters of reach with the scope. So I used to do a lot of those in my office and had a lot of fun doing it. But then I gave it up. I found a couple of good gastroenterologists that I could trust my patient to. I said, okay, I'm going to let them do those things, and I just concentrate on the other part of medicine.
So how important is that area?
The colon is extremely important. So many people, people can die a horrible death from colon cancer. They end up having a bag put in. My father-in-law, he was a smoker. And he died, from colon cancer. Multiple admission to the hospital toward the end of his life. So I got to live with a cancer patient from the large intestine, hands-on, and I saw, what they go through, along with my family. So it is horrible. It's really something that is horrible, but it's preventable. So how do we prevent it? Well, when you get a colonoscopy, what we look for is to see if you have several things. For colon prevention, we are looking for polyps. And if you have any polyp, if they are small, we can take them out. And why do we want to take them out? Because usually a polyp that is benign, the tip of the polyp can become cancerous. So if a polyp is like your little finger, and then the nail become cancerous of the little finger, that cancer now start growing into the body of the large intestine, and that's how it spread into the liver and the lung and the bones and the brain and everywhere else. So if we find a polyp, even if the tip of the nail of the little finger is cancerous, and we find it on time, we can strip the polyp out before it grow into the rest of the body. So, a lot of people are lucky enough that they do get their colonoscopy at the age of 50 and and they do their follow-up. Now, the reason we do colon screening every 5 years is because a polyps take about 3 years to grow. From nothing to become a polyp, it take about 3 years. Nowadays, the American Gastroenterologists Society have decided that you can wait in people that are very low risk. You can even wait 10 years without having a colonoscopy.
So in other words, when I went and had my colonoscopy and there were no polyps and nothing, then I'm a low risk and there's no one in my family.
Exactly. You don't smoke
no,
and all of
right.
that. You can wait 10 years and you'll be okay to get your next colonoscopy.
Because Dr. Mencia, I can't feel that I have a polyp.
You won't feel
you
anything.
Don't know anything.
You don't know anything. When you do find out, let's say if you start seeing digested blood or bright red blood, digested blood usually look dark. It's like when you drink a good wine and your stool get dark. Digested blood is usually dark. So the stool look between brown and spot of dark area. So then you think, well, I'm having some digested blood coming through the stool. And people usually don't make the association. They just think they're having just dark stool. If it's, extremely dark stool, then you know that you are bleeding a lot and that blood is being digested before it comes into the toilet bowl. Bright red blood usually means that the site of bleeding is very close to the rectum. Let's say like a hemorrhoid. If a hemorrhoid bleeds, it will, and it's very close to the rectum, so the blood is going to be red. When you wipe yourself, you're going to see blood in your toilet paper. So you know that that's usually something benign and usually coming from hemorrhoid. Nevertheless, a rectum cancer, meaning a cancer that is very close to the anus, to the surface, can present just with bright red blood. So don't assume every time you have bright red blood that it's only a hemorrhoid. You can only assume that if you have your colonoscopy and you know that everything was okay, you're still within the 10 years or within the 5 years, and there is some bleeding, you can say, you can assume most likely it's a hemorrhoid and you can treat it accordingly. The other benign condition that tend to bleed is diverticulitis. And diverticulitis is the opposite of a polyp. A polyp is the little finger sticking out when we put the sigmoidoscope into the colon to look. And a polyp sticks out like a mushroom. A diverticulum is a little hole that go into the wall. They are little pouches that you get into the wall. And they become important because those little pouches, when you eat seeds and nuts, they can launch into those pouches and give you the same thing that will happen in the appendix on the right side. It will give you a appendicitis-like picture on the left side, on the left lower quadrant of your abdomen. So people will have that pain on the left lower quadrant of their abdomen. If it's a woman, they think it's their ovary or something like that. If it's a man, there is nothing else that will do that by diverticulitis. And it's treatable. It's treatable with antibiotic if you usually start early. And there are complications of it if you ignore.
Is it painful?
It's painful. Yeah, you will know when you have diverticulosis, means that you have those pouches throughout the colon. Diverticulitis is when they become inflamed. And when they become inflamed, they will be painful. There's no ifs, ands, or buts about it. They will become painful. And the moment you start taking antibiotic, I usually have my patient that they tend to get bouts of diverticulitis. I usually have them have at home a course of antibiotics. So the moment they feel the pain and they drink water and it's not going away, on that day we start on treatment. So I have a lot of my patients that they will not end up in the hospital. They will not end up with some of the complication of diverticulitis, that they can be ugly. You can end up with a bag that can be permanent. So I take diverticulitis very seriously. And we can prevent the bouts of diverticulitis by learning what the presentation is like and knowing what the treatment is and starting the treatment, especially if my patient is going on a cruise or going on vacation to Europe or, away from the United States. Okay, take your antibiotic with you. If you don't use it, amen. But
so I have some questions. Why is an antibiotic is for infection? Is it infected?
Well, yeah, it's inflamed because remember that you have stool in there, right? And it's not clean. It's not, it's contaminated area. So the moment you get any inflammation in the colon, it's like when you get the inflammation in the urine, right? It can become cystitis. It's not completely sterile. There are bacteria that hang around in there. So the same thing, remember the colon is bringing all the waste material to come out. So it's not a clean area. So the moment you get any inflammation is opening the door for any bacteria now to penetrate that tissue. And it's a good question what you ask, because once you get bacteria to grow in there, you get an abscess in the colon. And that abscess can burst into the other side. Now you have a perforation of the colon. It becomes a catastrophe and an emergency surgery. And when the colon that is contaminated, is not clean, burst into the intestinal wall, the abdominal cavity that is sterile. Of course, now you have to open that patient up. You cannot close them back up. You have to leave the patient open. And you have to cut the area that is infected, rinse it every day. It's a huge process, and patients die with this thing. So,
when people have bags, then they have to, do they have to have a bag?
They end up with a bag, yes, absolutely. They will end up with a bag, and you see they have ugly scar because, they have to, the abdominal wall cannot be sutured together. You have to close by itself.
This is very amazing. We've never talked about this, but then diet must be very important for someone that has this. That
if you have, well, we spoke a little bit about constipation. Constipation is the root of diverticulosis. So if you suffer from constipation, you don't talk to your doctor about it because of whatever reason, or your doctor don't pay attention to you because of whatever reason. They think that you should live with it. And we are not aggressive treating constipation. Of course, we're going to get hemorrhoid. With the hemorrhoid, we're going to get the weak sphincter. We're going to have stool. We're going to soil our underclothes. And you're going to get diverticulosis. Because diverticulosis, those pouches come out because you're straining every time you have a bowel movement, where the wall of the large intestine is like a balloon. So you start blowing the balloon too much. One of the wall of the balloon will weaken and create those pouches. Except that in the colon, because we don't have that much space, they are quite tiny. But the base of the pouch can be big. So you can have food going in there, and eventually all the food start fermenting, start getting all contaminated, and that's how the pain comes to be.
And so when you have a patient, you really don't know unless you do an examination of their colon that any of these things are taking place, right? Or do you?
Well, no, we know if the patient talk. If the patient feel comfortable with the doctor and they say, I used to have a bowel movement every day. Now it's like every third day. Is that normal? And the answer is no. If you have to strain yourself to go, if you have to use your finger to help the stool come out, if you're doing things that are not what you used to do, the last thing that you want to do, especially in my book, in my world, is to blame it on your age. Because I tell my patient, there are many people, older than you that don't have to do what you do. So it's not normal.
Yay, that's good. They're picking on I was just having a talk with Darwin Porter, who's our celebrity writer, about the presidents, the potential candidates, and they're talking about people in their 70s being old, and by the time they're 80, and I'm just getting started.
Of course, yeah.
But anyway, getting back,
and the experience they bring with them,
of course.
But
getting back to this, so this has been quite an explanation. Now, years ago, when I went to the doctor, I would have something that I'd have to take home with me, and I would test my bowels with a...
Right, to check for blood.
Yeah, but they don't do that anymore.
Because by the time those things come positive and you have blood, if it's colon cancer, it's probably advanced. It's it's like putting a bandage on colon cancer. Let me wait to see if you develop colon cancer so we can do something about it.
So you're saying colonoscopies are very, very important?
Very important. If you are at high risk, there are blood tests you can do that is tumor markers. There are tumor markers for the ovary. There are tumor markers for the pancreas. There are tumor markers for the colon. So, sometimes when the patient come to my office, I order the tumor markers to give them peace of mind. With the tumor marker for the colon, if you get one test done, if you are a smoker, you will have a tendency of having a higher number than normal. And it's okay because the fact that you smoke. So we have to factor in. You have to make sure that your doctor, if they do the test, they know that, hey, I'm a smoker, I'm a heavy smoker. So when the tests come back, if it's high, you don't have to go crazy doing all kind of tests. We know that it's because of the cigarette that the marker is high. Having said that, if you are not a smoker and the level is above normal, then you need to have a good workup. Now, until recently, we know about the light that goes in through the rectum and through the mouth, called the scope. Nowadays, we have a capsule that has a portable camera in it. So you swallow this capsule, and the capsule is important because the capsule go down and start taking picture. It's like
this is great.
Yeah, it's like
Disney World.
Yeah, Lost in Space. Remember those things? We used to watch those series, and we say, "Oh, that would never happen. Oh, that's sufficient." But look, things happen. So it's a camera, it's a capsule, and it has a camera, and it will go down taking picture, and then it goes and it gets transmitted into a computer, and people look at the picture. And there is a use for that. We still like the colonoscopy and the endoscopy that we use, because with the colonoscopy, when we go in, if there is an area of concern, we can pull back, we can turn the camera any direction we want, we can take a biopsy right then and there. So we can do a lot of things with the scope. We have more control than with the camera. The camera just takes pictures, it doesn't take biopsy. The good thing about the camera is that if you have a person that is bleeding and they do the colonoscopy and everything come back clean, and they do the endoscopy and they don't have a bleeding ulcer, the part that we don't check with the scope is the small intestine. Because, the large intestine, we put the light in through the rectum, we go all around to the beginning to the end of the small intestine. And when we go through your mouth, we go down, we look at the esophagus, we look at the stomach, and we look at the beginning of the small intestine. But we don't go into the small intestine. We don't have them, that equipment to do that. So the camera becomes useful for those patients that might have any condition, celiac disease, or any condition that belong to the small intestine that before we couldn't get to, now we can get to them with the camera. And even some rare cancer that present in the small intestine. Now with the camera, we are able to detect it and take it up, go to where the problem is. And that's important because before we had those cameras that we can swallow and take those pictures, if there was a concern of some form of cancer, we have to open you from sternum all the way down to the pubic and open the belly and start searching for any lump or anything like that. Now with that camera, we say, okay, it's 30 centimeters down from the beginning of the small intestine. So we can go and make a little incision and put the scope down and just cut that small area, close you back up, and home you go.
Amazing.
So,
amazing.
It has revolutionized the care of the colon.
Glad we talked about this. Let me tell everybody this wonderful man, our wonderful doctor that's on with the Wonderful World of Wellness is Dr. Andy Mencia, and he has 2 offices, one of which is in Fort Lauderdale. It's his main headquarters, and that's at 1608 East Commercial Boulevard, Fort Lauderdale. It's just a little bit west of Holy Cross Hospital. The phone number there is 954-489-1345. And now in Boynton Beach, off Hagen Ranch Road, they have another AGI Medical and Dental Center, and that's 561-270-6494. Home visit services are available for homebound patients. That's the most exciting, I think, thing that they are doing as far as I'm concerned, and they're in Tri-County. So anybody that needs this service, you now know where to go. So if you want to get online, you can see a lot about them at agifl.com. You know, anybody who really doesn't, you don't write these numbers down as you should because it is Pencil Talk Radio. Okay, you can still call our office and we'll certainly direct you to Dr. Mencia and his wonderful staff. Well, let's keep going. This is a wonderful topic, Dr. Mencia. I am very, very, I feel like a virgin on this topic. Had to get some sex in there here.
Yeah. Since we have the Pencil Talk, for the listener, the tumor marker that you can ask for is called the C as in Charlie, E as in Echo, A as in Apple test, CEA, and it stands for carcinoembryonic antigen. So you have antibody and you have antigen. It's an antigen that is produced to sort of fight the cancer. And so it's a CEA level. So when you go to the doctor, if you are at high risk, you might want to ask for that test. I say, I want to get a CEA level because my father, my brother, somebody in your family was diagnosed, especially if it's somebody close in age to you. You want to get checked.
Yeah, but if you're the doctor, you're going to request that for them.
Sometimes, but sometimes I always say, we are the consumer. This is a business. I have dinner with the group that they do HMO. And they were telling me how much money they can save and how much money I can make if I join. And if I have so many patients, I get capitated, which means I get a check every month, whether I see you or not. The less I see you, the more money I'm making. And so there are people out there doing the business of medicine and it becoming a dirty business. And that's why I want to stay as much as possible with private insurance so I can practice medicine the way I like to. So a lot of times you have to be a smart consumer. There's nothing wrong with you doing your research and you coming to me and say, this is what I think. I had a patient that I saw this week. He's a listener to our show. Young guy, and he take very good care of himself. And I say, I'm going to do some iron study. I'm going to do this. And then the nurse reminded me, he's self-pay. He doesn't have insurance. So I said, let's back up. So I told him, usually when I go into the room, I don't look at the insurance. I look at you and what you need. But yeah, we can wait. There's nothing wrong with waiting. It's not that bad. Thing can wait. So you need to know what you need. It's a tumor marker. Ask for it if you think you deserve it.
Before we go
off the air, I want to remind people that if we say you start doing colonoscopy at age 50, when do you do it earlier than that? If you have had colon cancer in your family at an earlier age. So let's say if your uncle have colon cancer at 40, at age 33, 32, you want to have your colonoscopy.
Great. Well, Dr. Mencia, this has been a wonderful topic. I hope that nobody has had problems, but you know what to do now.
Prevention.
Prevention. Yeah. And go see Dr. Mencia. He's the big preventer.
Yes.
Thank you, Dr. Mencia.
Thank you, Anita.
Thanks for listening to The Wonderful World of Wellness with Dr. Andy Mencia. Be sure to tune in each Saturday morning from 7 to 7:30 right here on WSBR 740 AM.